My name is Jennifer Moritz. The procedure I'm having done today is upper eyelid surgery. I chose Dr. Zelken because of his experience working with Asians. He's trained not only in the US but in Asia as well, so I felt like he is the best surgeon to handle this procedure. My goal would be to not experience any pain and not hear anything that's going on, and to obviously look really great at the end. I would like subtle results. I would still like to look like me, but I would like to look refreshed, a better version of myself. So my experience so far has been great. Really, really helpful, informative, educated. I've texted them multiple times throughout the week asking questions, and they've been super responsive.
Hi, I'm Dr. Jonathan Zelken. I'm a board-certified plastic surgeon. Today you will see an Asian double eyelid surgery. This is an operation that really is refined towards the Asian anatomy, and differences do exist. For example, in Asian monolids, you don't have that fold above the eye opening because fat tends to herniate from above the eyeball and down and stop that fold from forming. So in Caucasian blepharoplasty, when we simply take out skin and fat, it's a matter of closing the skin and being done with it. In Asian blepharoplasty, things are a little different because we have to create a fold where no fold exists. So symmetry is doubly important in Asian double eyelid surgery because not only do you have to have symmetric markings or correct for existing asymmetries, but you've got to make sure both the skin excision and the fold placement are perfectly symmetrically placed. So this operation takes at least twice as long as a typical Western or white blepharoplasty procedure. Other important differences exist. For example, the fold in a double eyelid surgery tends to be a little lower than what we'll typically do in a Caucasian. This is because it just looks better that way. A lot of swelling occurs after surgery, so you can't tell that the fold is closer to the eyelid margin. All the swelling goes down. You'll see that these differences really are subtle but important. The other thing is we take out a little bit less skin. Even in the aging upper Asian eyelid, there's no question whatsoever that conservatism is key. If you take out too much skin, and especially if you take out too much fat, you get this hollowed out or fake look that just doesn't look good. There are entire textbooks that exist on this subject. It's no joke. And you need to find a plastic surgeon that knows the differences, not only in terms of anatomy, but in terms of cultural and individual patient desires. If you ignore any of these things, you will have a failure on your hand and a very upset patient. In this technical video, I want to go through some of the subtle differences that exist and some of my personal preferences. Any plastic surgeon you talk to is going to have their opinion on the subject. I stand behind three different ideals. Number one, less is more when it comes to Asian double eyelid surgery. Number two, symmetry is key. Measure 4 times, cut once. And number three, and most importantly, make sure you know exactly what it is that the patient wants, because this is not a one-size-fits-all operation. I start this operation just like I'll start any other, and that's with numbing and marking. I mark before I numb because I don't want to make sure that my marks are high or low because of the swelling of the numbing medication. Again, I make my incision about 5 to 6 millimeters away from the eyelid margin. That's different than the Caucasian, which is 8 to 10 millimeters away. I'll mark these very carefully, and I don't want the incision to extend more than 5 millimeters past the crow's feet because you'll see it. Number two, after marking, I'll offer my patient a gentle oral sedative. This is optional. On the flip side, patients can also get IV sedation or be put to sleep if they wish. Most patients opt for oral sedation. I then take my patient back to the operating room where, after prepping and setting up the operative field, I will apply more numbing medication into the upper eyelid. This numbing medication, just the injection of it, can cause a lot of bruising, so I try to use as few needle injections as possible and use that numbing to actually hydrodissect. After doing this, I will cleanse and prep the entire field with betadine, which is a solution designed to sterilize the field. Next, I will drape the patient in standard fashion as you've seen me do before. I then take a number 15 blade, which is the sharpest blade I have, and I incise through the skin only. I don't cut through the muscle at this point. After removing the skin with scissors, I will clean up the field with electrocautery. I then take a very fine pair of forceps or pickups and I'll cut a little bit of muscle to identify something called the orbital septum below. This contains the fat and is what kind of falls down, leading to that monolid appearance. So I will cut through the orbital septum, identify the fat, and sweep it upward. Next, I'll identify the pretarsal tissue, which is above the cartilaginous portion just underneath your eyelid. I'll cleanse all the tissue from that area, including debulking additional muscle on top of it so it doesn't stay so swollen and puffy. Once I identify the tarsal border, I'll then take a stitch and I'll triangulate that stitch from skin and muscle to the bottom, to the floor or the tarsal plate, back to skin and muscle. When I close this, I'm actually triangulating the tissue down and creating a very carefully defined eyelid fold. Immediately upon asking the patient to open her eyes, you'll see that that fold is created. You can see the difference between her right eye and her left eye where that has not been done. I then will continue through and do a series of interrupted stitches through the skin that come out later. I don't like leaving buried stitches behind. After putting about 7 or 8 per side, I'll then use a standard finer suture that I use in microsurgery to close the incision, as you've seen me do in every other blepharoplasty that I perform. At this point, I'll turn my attention to the patient's left eye, and I'm constantly asking her to open and close her eyes. That funny looking contact lens you see is a stainless steel eye shield to protect her eye from me. I then do the exact same procedure on the patient's left eye. You'll also notice that I use something called bipolar cautery to minimize trauma to the surrounding tissues. I don't like to inject too much numbing medication, and I certainly don't like to cause trauma because this leads to a lot of early swelling and can affect the results in the long term as well. After I closed up the entire left side, I again assess for symmetry. Because the left side is a little bit fresher, she has a little bit more swelling, but I can still sense, I know that everything is within a millimeter of each other, and I consider this a successful on-table result. I assure the patient that this is going to be beautiful, and I can assure you that she didn't feel a thing during the entire procedure. After this, unlike Western blepharoplasty, I don't think taking out volume is a good idea at all, and in only few cases, these typically will be reserved towards the Korean population, will I resect fat. I don't like to do it. If you look at her mom, and if you look at her, this patient, you'll see that she's starting to get hollows naturally that need volume added and not removed. This is definitely in vogue in Asian blepharoplasty today, and is definitely not an out-of-the-box concept. I use Juvederm Ultra Plus XC to volumize some of this hollow. Even though I've already added some numbing medication, I previously marked areas that I felt were volume deficient and applied a very conservative amount of volumizer in the form of Juvederm Ultra Plus XC to the hollows. By doing this, I create a much smoother brow eyelid junction, and there's not as much of a hollow. Everything is about conservatism in this operation. I only used about 0.2 to 0.3 cc's of Juvederm Ultra Plus XC hyaluronic acid filler per upper eyelid sulcus. By placing a small amount of hyaluronic acid filler, 0.2 to 0.3 cc's, I can actually add volume to the midface and eliminate some of the concavity that comes with aging and the Asian face. Finally, I add Botox because no periorbital rejuvenation is complete without elimination of some of the furrows in her forehead. She had both static and dynamic wrinkles in her forehead, which are adding to her aged appearance. However, her brow is still somewhat immobile, so by paralyzing this, it's not going to affect the outcome of my blepharoplasty surgery. I thought about that, but I did not need to account for it for this particular case. After everything's done, I apply arnica and I apply Tobradex, which is a combination of steroid and antibiotic. My patients all go home with a specialty care bag from this institute, as well as a prescription for antibiotics, for narcotics, and for this Tobradex ointment that allows for healing through steroids and antibiosis. The patient comes back to see me at day 1 and at day 5 for suture removal. At day 5, all the sutures are removed. I'm going to expect to see a lot of swelling, hopefully not too much bruising, and the patient's going to be pretty good looking by 2 weeks and red carpet ready by 4. Having said that, her final result takes 6 months or longer to manifest. I hope you enjoyed this technical video today, and I look forward to meeting you. It's very important that you seek not only a board-certified plastic surgeon, but somebody who can understand and appreciate the differences between the Caucasian and the Asian eyelid.